disease. There's a subvariant that is autosomal recessive, but that's very rare. It's mostly ACPD, autosomal dominant polycystic kidney disease. There's two presentations. Like some patients, they present very early in life, like in their 30s to 40s, but most patients, they present later in life, like they become dialysis dependent in the 50s, 60s. That's more like the rule, like for these.
When do you start seeing the cysts?
You're not supposed to screen below the age of 30, because if you don't see the cyst, it doesn't mean that you're not going to have them. So there's a lot of anxiety, like if you have a patient with the condition, the best thing you can do is you can refer them to a geneticist, because we have genetic tests for the most common type, the PCK1 and the PCK2 genes. So they're able to tell them with certainty. The problem with that is you want to tell this to your patients. If you're ready to have the diagnosis, fine, but what I tell my patients is, like, just make sure your kids buy life insurance, they buy disability insurance, whatever else they need to buy, because once that thing is on your record, that's it. Forget about it. Nobody's going to insure you, or they're going to give you all sorts of exceptions.
So my dad has it.
Polycystic kidneys, right?
Yeah, and I don't have it.
But does he have polycystic kidney, like the adult autosomal dominant? Was any of your relatives dialysis dependent? How big are his kidneys, Dr. Ben-Zur?
Big,
Right, because the other thing is that he may have acquired cystic disease of the kidney, which is totally different, completely different entity. Because I don't think Mr. Ben-Zur has, because most patients with polycystic kidneys living this long, he would have already been on dialysis. He probably has acquired cystic disease. And he should probably get a renal ultrasound like every 1 or 2 years, just to do surveillance, because the acquired cystic disease of the kidney can actually have a slighter risk of malignant transformation of the cyst. But if he probably has acquired cystic disease of the kidney, it's not as aggressive as the polycystic kidneys, which is a genetic syndrome. Yeah. So
if you were to have it, for example,
Mm-hmm.
and you did have it, at age 55, I don't have any cysts.
You're fine. You're not going to have it. Yeah, you're fine. And so we don't recommend that you screen if the patients are younger than 30, but probably the easier thing is just refer them to get the genetic testing. On your boards, you may get this question: what is the disease association with polycystic kidneys? Berry aneurysms. Yeah. So that's you ask them. The guideline is if the patient has had a history of a sudden death, you need to do an MRA of the brain just to look for the aneurysms. If the patients are having symptoms, you need to refer them. If they have neither of the ones I mentioned, you don't screen. But honestly, if I were a patient, I probably would want to know if I have an aneurysm. But yeah, they do ask you for that. Okay, so polycystic kidneys. What other diseases of the kidneys you guys can think of?
Pyelonephritis.
Yes, we're going to talk about that one. It's a big topic. What else? Sorry? Pyelonephritis. Yeah, I mean, pyelo can give you acute kidney injury if it's severe enough, but typically you get the classic history of fever, chills. If it's unilateral, it's less likely. So whenever you see a jump in the creatinine this much, you always think about something involving both kidneys. Elderly are more susceptible. They have less adaptive mechanisms than the younger. But if you have a younger patient with a creatinine of 3, you think about a process that's causing damage to both kidneys, either bilateral obstruction, either a pruritinal state, or either a severe form of ATN. But pyelonephritis is usually unilateral, and not every patient develops AKI unless they're very sick, unless they develop sepsis or SIRS and hypotension-induced ATN.
In the hospital setting, can't CT contrast and so on.
Very good. Excellent. So drugs can actually is a big category. So he got anesthesia, like some of these anesthetic, maybe he had a idiosyncratic response. Antibiotics, like you mentioned, AIN. Some drugs are nephrotoxic. For instance, radio contrast. So which patients are at risk of developing contrast-induced nephropathy? You guys know, like, do you have the same risk that this guy? Age. So that's a major risk factor. The older you are, the more likely you have the risk of developing contrast-induced. What other comorbidities? Actually, there are three conditions that really predispose you to develop contrast-induced nephropathy. One is the age. The other one is having diabetes with diabetic kidney disease. Not just diabetes, but having pre-existing diabetic kidney disease. And the third one is multiple myeloma. And multiple myeloma, multiple myeloma can damage your kidneys in many different ways, but the favorite in the boards is the myeloma kidney. So there's a lot of urinary stasis because these proteins that they form, they're very sticky and they're very insoluble. And they form because the monoclonal immunoglobulin binds the Horst-Dampf protein. Remember that protein that's in the ascending thick of Henle? That's an immunoglobulin that we normally produce for protection of infection. So that protein becomes very insoluble and very sticky once it binds the Horst-Dampf protein, and it causes a lot of urinary stasis. So when you do a contrast study in those patients, for sure you're going to put them in renal failure, guaranteed. So in other words, a good radiologist and a good internist would know not to do a contrast study in a patient like this, because you're going to, when you do a CT, like a week after you do another CT, and you can still see the contrast stuck in the kidneys. And it's funny because the radiology, they still reported like contrast in the kidney. So it's very toxic. And ultimately, what happens with contrast? What kind of lesion does it cause in the kidneys? She said it. ATN. Very good. So you see? So ATN. The question is, why? What caused the ATN? So contrast is a big category. What else can go in the hospital, in surgery, in the post-surgical state?
1 second, because they always ask on board with me, what would you do if you wanted to prevent contrast-induced nephropathy?
You can hydrate them.
Great.
Prior to, and I think it's like Mesna or Mist or something.
Mesna is for cyclophosphamide, but for
Mucinex.
Mucinex, yeah. Yeah, Mucinex. Mucinex is great. It's very harmless. Some studies say it doesn't work. Some studies favor the use of it. So the way I see it is, if it doesn't hurt my patient, why not? Just give it to them 1200 BID times 4 doses, like to be started like 12 hours before the contrast study. What I do for my high-risk patients, I bring them into the urgent care. I give them IV fluids. Typically, if the patient doesn't have a contraindication, because if your patient has CHF, cirrhosis, or
what
like,
do you do in those cases? Let's say, 50% of our patients.
you make them. Yeah, you make them euvolemic. In fact, there's a question on the boards that I got it wrong. I'm very mad. It's like, if your patient has decompensated CHF, you have to diurese them before you give them contrast. That's the correct answer to the board question. It is counterintuitive. Like, you think, like, I'm going to give a diuretic to this patient and then I'm going to give him contrast. So the key point is, like, you need to make them euvolemic. But if there is a contraindication for fluids, don't give fluids. Just make sure they're euvolemic. And make sure you disclose that to the patients. Like, there is a risk of this dye damaging the kidneys. The risk is there. It's not a for sure thing. Like, I would say probably, like, even the patients that are very high risk, only like 30 or 40% of them would develop it. But most of the time these patients recover, so it's not a big deal. Like there's always like this big thing about like contrast and everything, but most of the patients recover. But some patients can be left with a new baseline, and some patients can be left like dialysis dependent. And that's the reason why I work very closely with cardiologists. When the patients are approaching dialysis, I usually communicate with them, because we decide on the right timing to do the angiogram. Let's say the GFR is 15, 16. Let's just make preparations. If the patient is not having symptoms, let's just make sure that we have dialysis access, and then you can do the angiogram, and we can start the patient on dialysis during the same hospitalizations. You guys know what kind of access, when I say access for dialysis? Do you know what I mean by that? Yeah, like, how do you deliver dialysis? But that's preferably, we never start anyone with a catheter, preferably. But in the real world, obviously, we use them. So catheters for your boards. Catheters are intended for patients with very short life expectancy. Let's say that you're going to die within the next 6 or 12 months. So you just put them in a catheter. Or if you're in a nursing home and you have really no way of going to the surgeon's office for follow-up, or able to tolerate the surgical risk of going going for an arteriovenous fistula, or the catheters are for patients that they exhausted every possible access in their bodies. But the preferred dialysis delivery method is with a fistula. Have you guys ever seen a fistula? So if any of you guys see a dialysis patient in Dr. Ben-Zur's practice, just call the rest and then just share with the other students so they can feel it. So that's the preferred route. Typically the surgeons, they aim for the distal. So the way they do it is Cimino, which is the ulnar AV fistula. If they cannot do it here for whatever reason, because they have poor targets, or they're most of the times diabetics, they have very poor vasculature, so they move here. If they cannot do it here, they do it here, brachial. If they cannot do it, they first choose the non-dominant arm, then they go to the dominant arm, and if they already exhausted everything here and everything here, then they go to the femoral. And then if you see a patient with a catheter, that means that they exhausted everything, or if they haven't exhausted anything, you need to tell the patient, you guys, you really need to get your fistula, because those catheters are just bad. You know what happens with those catheters? Go ahead.
What about the peritoneal?
And peritoneal, but that's for peritoneal dialysis. Yeah, so that's the other axis, like peritoneal dialysis catheter in your tummy, and then you have a AV fistula in your arm if you're doing hemodialysis. But you guys know what happens with those catheters? Why am I saying that they're terrible? Infectious complications and non-infectious complications. What are the non-infectious complications of these catheters? Thrombosis. So that's more and more interventions. What else? Bleeding, obviously. Like sometimes patients, they pull it during the sleep. You can bleed, and you can actually die if you don't apply pressure. And what else? Well, placement related complication, pneumothorax or hemothorax. And if you leave the catheter enough time there, like let's say that I have, usually the surgeons, because of the anatomical reasons, like the internal jugular vein is more easily accessible on the right than on the left. So surgeons usually place it on the right. If you leave that catheter there for a long time, like 80% of the patients after 1 year of having a catheter there, they will develop central vein stenosis. It's like your body is rejecting that. So it creates like growth of the endothelial and the media. And that may have clinical implications, because God forbid the patient needs some sort of intervention. Let's say he needs a pacemaker, and they're already using that vein. You're actually damaging the whole axis. Let's say the right arm, they won't be able to use it, because if you have severe central vein stenosis, the surgeons won't be able to create any vascular access. And then I had a patient actually once, it was crazy. The guy had a pacemaker, he had a defibrillator, and he had a dialysis catheter there. And nobody really do anything about the catheter being there. They should have just referred the patient to a good surgeon to create access somewhere else. The patient presented with edema in one side of the face. He had like a central, basically the venous return was so compromised that like his face was normal on the left, and the right side of the face was completely swollen, all related to a severe central vein stenosis. So again, those catheters are no good. If you see a patient, you educate the patient, you tell them this is no good, you need to get rid of that. But that's basically why we do that. So going back to the topic. So we covered contrast-induced nephropathy, and what else happens in the hospital in this post-surgical setting?
Just 1 second.
Yes.
Contrast-induced nephropathy. The worst scenario for me is somebody comes in with an MI. They're in heart failure. The creatinine is like 3 or 4, and they're diabetic, poorly controlled. Those are the cases that actually. You
have to go with the angiogram. Like I always tell the patient, and this is being studied. You have to tell the patient, we have a therapy available for you, which is called dialysis, but we don't have a therapy available if we don't repair that LAD lesion, or if I let you walk away with a life-threatening lesion. So the heart takes precedence over the kidneys. That's basically, you need to tell the patient and the families. But yeah, it's a pretty ominous scenario, but it is what it is. And if you think about it, those patients, when they present like that, the teaching point is like, we always concentrate about the small picture, which is the number. But if you have a diabetic with that severe degree of disease that he presented with an MI, and And the reality is that that patient is going to be dialysis dependent. That's the reality. It's just a matter of time. Like, when is this going to happen? It's just going to happen now, or it's going to happen in 2 years. Remember, there's no available therapies for diabetic renal disease. It's just ACE inhibitors, control of diabetes, control of blood pressure. Some studies suggest the use of some medications like pentoxifylline, but there's really nothing effective to arrest the progression of the diabetic renal disease. Once you see a patient, like I get this all the time in my practice, and I hate when that happens because, you know, like the most important thing you can do as a doctor is to build trust and develop a relationship with the patients. So when I get a diabetic that comes into my office, recently I had one, he came in with a GFR of 17 with 6 grams of protein with end organ damage. The patient was almost blind, proliferative diabetic retinopathy, severe peripheral neuropathy with erectile dysfunction, like burning sensation in the feet, whatever, orthostatic hypotension. So he comes in and he basically came to me telling me, like, you know, I'm here because I need to get my kidneys better. I know for a fact that those kidneys are gone. I mean, the minute that I meet this patient, I know they're gone, because one of the things that happen in diabetic renal disease is when you have a lot of proteinuria, these patients, the GFR is overestimated, because there is a lot of, like, in severe proteinuria, there is a lot of, remember I told you that creatinine is filtered and is mildly secreted in the proximal tubule and is not reabsorbed. What happens in diabetic renal disease with a lot of protein is that the creatinine is filtered and it's over-secreted in the proximal tubule. So this patient has a GFR that's 16, but when they do actually nuclear medicine studies to measure the GFR, the real GFR is probably 8 or it's probably 9. And one of the problems that I deal with as a nephrologist is that my patients feel fine. So for me, it's hard to convince them that we need to make preparations for dialysis or preparations for transplant. On your boards, remember, the right answer to that question is always do preemptive transplant. That's the right answer on your boards. But as a nephrologist, so I get this guy, and then the next time he comes, his GFR is 14. And the next time that he comes is 13. I tell him, like, I need to talk to your family because he's not following through with my recommendations of seeing the surgeon and completing the transplant evaluation. So he comes in with his son, and the son is all, like, very aggressive guy, like telling me, like, you know, I don't think you're doing, you know, you're not playing with medications. Like, well, you can see any nephrologist in the world, it's going to tell you the same thing. Your dad's kidneys are gone. So when you're confronted with a scenario like that, if you see a patient with diabetes, a lot of proteinuria, a lot of end organ damage, you know for a fact that those kidneys are gone. So what you need to do is you need to move fast to be able to get that patient a transplant. And we talked about transplant the other day, right? A little bit? Talk about it? Okay.
We have a patient whose blood pressure is like 200.
He needs dialysis.
Over the last, like, 6 years, he started out with pretty much normal creatinine.
Uh-huh.
Non-compliant, he's seen, like, multiple nephrologists, he's been on multiple medications. Who knows why his blood pressure is not controllable? Part of it is just not compliant. So now he's basically, you know, near renal failure and going for transplant now. Still, his blood pressure is 200.
He needs dialysis. That's one of the manifestations. Remember indications for dialysis? You guys remember? What are the indications for dialysis?
Acidosis.
I'm sorry?
Acidosis.
Right, very good.
Electrolyte abnormalities.
Which one? Refractory hyperkalemia. Mm-hmm.
Intoxication.
Some of the poisonings, yeah, you need dialysis.
Fluid overload.
Fluid overload. Mm-hmm. And his patient. Uremia and his patient. What else? Refractory hypertension. This guy.
Is that he's refractory before, when his creatinine was normal. You know what I mean? He's going to get transplanted.
But I mean, that guy needs dialysis. Seriously, that's the only way that you can control somebody with, like, say, GFR of 15, blood pressure of 200. You can pump all the medications in the world. Sometimes you can't bring them down. You need dialysis. You know, these patients are very volume sensitive. In fact, you know, when I talk to you guys about hypertension, that's a separate lecture we're going to do. If you have a dialysis patient or somebody who is approaching dialysis, like, the right thing to do for that patient is to lower the weight. It's not play with medications. I mean, obviously you're going to try to do something to help that person in the meantime, but the definitive fix for this patient is to lower the weight, lower the dry weight. You know, and this is an important concept that you educate your patients. You know, let me make it simple for you guys. So once you go on dialysis, and you go to a dialysis unit, they teach you that you have a dry weight. So when you interview a patient in the ward or in Dr. Ben-Zur's clinic, you ask them, what is your dry weight? Everybody knows what their dry weight, unless they're clueless, but everybody knows, like, my dry weight is 70 kilograms. And the dry weight is the weight that they're expected to meet once they're done with dialysis. So they go in, they 73, they're gonna get 3 kilogram removal, and that's the number where you know that your body's happy. You know, you have no edema, you have no shortness of breath, and your blood pressure is well controlled. So what happens is that some dialysis patients, they don't follow the fluid restriction or the sodium restriction. They feel that I'm already on dialysis, I can eat and I can drink whatever. Guess what? Once you become dialysis dependent, you're even more restricted in every aspect, because you're not supposed to gain more than 1 kilogram per day. You know, remember, dialysis is done, hemodialysis is done Monday, Wednesdays, and Fridays, or Tuesday, Thursdays, and Saturdays. So there's 2 days in between the treatments, and for the weekend there's always 3 days. So they're not supposed to gain more than 1 kilogram per day. But some patients are not following through with these recommendations. So they drink. They feel very thirsty, by the way, and they drink, and they go in the dialysis unit with blood pressure of 205, 6, 7 kilograms. The other day I got a woman, she ultimately passed away. She was gaining between 9 to 11 kilograms in between treatments. That's outrageous. That's like, imagine the lady was gaining 20 pounds or more in between her dialysis treatments. Obviously, the heart gave up. You know, she had like so much myocardial stunning from doing so much dialysis and chronic volume overload that she ended up, she had a cardiac sudden death. We don't know what happened. I mean, probably she just had an MI and died. But anyway, so the bottom line is that if you have a dialysis patient, they have to be fluid restricted, sodium restricted, and we target an estimated dry weight. So when you interview a patient, just do the exercise. What is your estimated dry weight? Especially if you're dealing with hypertension, what is your estimated dry weight? Are you following sodium restriction? Are you following fluid restriction? If yes, how much do you drink? And you guys know from now on that they should not gain more than 1 kilogram per day. Okay? And
How do you pick up multiple myeloma?
The symptoms are like back pain, and then like X-ray.
like the lytic lesions.
The lytic lesions.
Okay.
I'm sorry.
I said back pain and then lytic lesions on the X-ray, and then hyperviscosity of the blood, and then Jones proteins.
What else? What do you see in the urine?
Immunoglobulin.
You see, like, this is a question you're gonna get on your boards. You see a mismatch of proteinuria. So you see no urine in the UA, no protein in the UA and the dipstick. Then you see a lot of protein when you quantify the proteins, either with a 24-hour urine or with a spot urine for protein creatinine. And the reason is that the dipstick only picks up albumin. But you just said it, they don't have albuminuria, they have Benz-Jones proteinuria. So those are like light chains. And the light chains, they only light up when you run the sulfacylic acid assay. And that's only done when you quantify 24-hour urine, or when you do the spot urine for protein creatinine. So if you see that mismatch, you're gonna get a question like down your boards. You suspect multiple myeloma. And one important thing that he probably wanted you to answer is anemia. These patients are anemic. You know, anemia, renal insufficiency. Like on your boards, they're not gonna give you like the medical mysteries. They're gonna give you all the aspects: the bone pain, the elderly male or female with lytic lesions, renal insufficiency, anemia, Benz-Jones proteinuria, or the mismatch of the proteinuria. And if you want to be more sophisticated, they have a very small anion gap. These patients have a very small anion gap because the paraproteins, they account as cations. So, you know, instead of like having like a normal anion gap is 10 to 12, these patients have like an anion gap of 5, 4, 3. And that's another clinical hint to think about multiple myeloma. Okay, so, all right, so I was going towards another very common scenario of renal failure in the hospital patient, in the hospital setting. Do you guys remember? Sepsis, very good. Sepsis is one of the most common causes of acute kidney injury due to ATN. Typically the patients, they give you a history consistent with sepsis. Yeah, but ultimately it's ATN. But what else? After surgery, or let's say you have somebody who presented with seizures, or somebody after like had a crushing injury. Rhabdomyolysis. So rhabdomyolysis is it's always part of the workup. So when you get consulted with a patient with acute and systemic symptoms. But in the setting of acute kidney injury, acute uric acid nephropathy is seen in the setting of tumor lysis. Okay, so and then we talk about prerenal, we talk about intrinsic, and we talk about post-obstructive. Okay, why don't you help me read in the second paragraph?
The patient has symptoms of congestive heart failure. He has not been extremely thirsty over the last several days. He has had difficulty urinating over the past several years with the weak urinary stream and nocturia 3 to 4 times per night. His doctor told him that he had BPH, but no therapy was given. The patient denies leg pain or flank pain. A hospital chart was reviewed which showed the patient had significant bleeding in the operative period with several episodes of hypotension with systolic BP in the 80 range. These episodes lasted for short periods of time, less than 5 minutes, and returned to normal blood pressure after this period. His urine output was 700 mils per day immediately after surgery and dropped to 200 to 300 mils per day over the past 2 days. For the 3 days after surgery, his total fluid balance is positive 3 liters. His only medication post-op was anesthesia with Dilaudid. He did receive 1 dose of cefalothin preoperatively and none since that time.
Okay, so is it helping you, this historical information I'm giving you? So he doesn't have any symptoms of congestive heart failure, and he's not very thirsty, he's been eating, so we rule out prerenal, right? And I mentioned that he has some difficulty urinating, and he does have some history of nocturia. So, and he's a male, an elderly male. So we always check PVR. We already know how to do that in the hospital or in the clinic. You guys already know. And I'm giving you also that the patient didn't really have any significant bleeding, so we're ruling out hypovolemic. But that doesn't mean that he could have a hypotensive episode, explaining whatever happened to him. But at least we know that it wasn't like a hypovolemic shock. And they mentioned that his systolic blood pressure went down to the 80 range. Is that normal? Is that abnormal? Or can that explain whatever is happening right now? That's too low, right? It is low, yeah. Especially if you're elderly, your blood pressure, say going into surgery was 130, 140. If you have these drops, that in itself is enough to cause ATN. The kidneys are very sensitive organs. In fact, they're the first ones to go down when something's going wrong. Like when the patients get septic, when the patients have a major cardiac event, when the patients develop like liver failure, you know, the so-called the hepatorenal syndrome, the kidneys are the first one that go down. And the pathway is the same, ischemic injury to the kidneys, ATN. But our job is to identify what caused it so we can implement the measures to prevent it. So definitely that's an important historical information I'm giving you, systolic blood pressure in the 80s. And then his fluid balance is positive 3 liters. What does that tell you? Has he got enough fluid, or you want to give him more fluid? Or 3 liters and he's not peeing much, you want to back off on the fluids, right? And this is quite common clinical scenario in the hospitals. Doctors, we do it all the time. I include myself. I've overdone IV fluids, and I probably caused pulmonary edema, and probably one patient in my career ended up being intubated. So I'm using this example to teach you guys that normal saline is a medication, and you have to be cautious about the risk, the benefits, and the indications for use. And every day, as an intern, as a resident, you need to ask yourself, do I need to keep the fluids on board? You got to be cautious, because you can harm a lot of people if you don't pay attention. Some doctors, they just put the patients on IV fluids, and I'll see you. And the next thing you know, the patient's in the ICU with a intubation. Okay, so why don't we go to the third paragraph, please?
Patient's physical exam shows his temperature 37, risk for 14, BP 130 over 90, pulse 82 with no orthostatic changes. His mucus membranes are moist, neck page were 1 centimeter above the sternal angle. And patient's lung exam was clear to all circulation and percussion without rails. Cardiac exam was normal, S1, S2 without escalator murmurs. The patient's abdomen was soft with slight tenderness over the cervical spot. No ecchymosis was noted. The The patient had no CVA tenderness or ecchymosis present in the back. A Foley catheter was placed in the patient at the time, which showed approximately 50 cc of urine in the patient's bladder.
So let's break it down. So basically his physical exam right now, he has euvolemia, right? You know, how do you assess the volume statin in your hospitalized patient? What are the physical exam findings? Hospitalized patient. Where do you look for fluid?
Check skin turgor.
The what? I'm sorry? The
Skin turgor.
Oh yeah, skin turgor. Yeah. What else?
Mucous membranes.
Mucous membranes. What else? JVD. What else?
Pulmonary exam.
Pulmonary exam. Very good. Where do you look for edema in the hospitalized patient, the bedbound patient?
You said that.
Sacral. Yeah. Yeah. So you look in the thighs and you look in the sacrum. Because once you're there, there's no gravity, right? You've been in bed. Most patients are in bed. So to be thorough, you do a good exam. You look at the thighs and the sacral area. Okay. So he's euvolemic. His cardiac exam is pretty unremarkable. And his abdomen was soft. I told you that there was no ecchymosis or hematomas. When you have a retroperitoneal bleed, which is like an operative complication, you look for hematomas in the flank. So when you have a patient with hemoglobin drop and you don't know where the blood is, what are the three areas that you look for? And so you're the intern, your patient's hemoglobin dropped significantly, the patient was on a heparin drip, what do you look for that blood? GI. You do a YX stool test, is negative. Where else do you look for that blood?
CSF.
Not enough space to have a significant drop. What else? What do you think a guy's blood accumulate in your patient?
Pelvis.
A retroperitoneal bleed. So look at the flanks. Look for ecchymosis on the sides. Where else?
The pelvis.
In the thighs. You can get a like trauma surgeons actually like you can go into hypovolemic shock just bleeding into your thigh. And what else?
Chest.
In the chest. So you do a chest X-ray. You know, sometimes we just scan the patients. We just do. You know, you guys are practicing in an era where you send a CT for everything. You know, back in the days, we used to have to think about like, okay, let's do a chest X-ray, let's do a good exam. But yeah, so think about chest, retroperitoneal, and thighs. Yeah, especially like Dr. Ben-Zur, for instance, he's doing arterial punctures. He needs to be vigilant, and that's why he keeps the patients in the hospital, just to do a groin check and a distal pulse exam, just to make sure that he didn't cause a complication associated with the procedure. Okay, so let me see. Okay, and the Foley catheter. So we pretty much measure a post-void residual is 50 cc's clinically significant. It's not. So that's not. So we rule out the post-obstructive, right? Okay. So what would you like to order, like lab-wise? What kind of blood test do you want? What kind of urine test or blood test? What do you want to order? CBC. What else do you want to order? A UA. Very good. What else? A CPK, a CMP. Very good. Okay. Why don't you help me read the next paragraph? Let's go to the workup of this patient.
A fresh specimen of the patient's urine is examined under the microscope and showed numerous epithelial cells and brown degenerating cellular mass. No crystals or WBCs were noted, and only rare RBCs were present. The urine sodium was 40 mg per liter. Urine specific gravity was 1.01. Repeat media when examining on the fourth day after surgery are DNP2 and creatinine 3.5.
So they keep up trending, right? Okay, keep going.
And the uric acid was 9.2. A renal ultrasound is done. Kidneys are normal in size and no signs of obstruction.
Why do we do a kidney ultrasound in the setting of acute kidney injury? What is the question that you're asking the radiologist? You look for hydro, pretty much. You know, sometimes like as a nephrologist, I look, if I suspect this is not just ATN, I suspect that there may be something else going on. I always do an ultrasound because I need to make sure that, number one, the patient has 2 kidneys. You don't want to do a biopsy if he only has 1 kidney, because if something goes wrong, the patient is on dialysis. And number 2, You look for structural abnormalities of the kidney. Sometimes we see horseshoe kidney, and we look for tumors, we look for stones, we look for any cysts. You can either have simple cysts or you can have complicated cysts of the kidney. But primarily in the setting of an acute kidney injury consultation, you're in the intern, you're the resident, you're looking for hydro, rule out hydronephrosis. And to have hydro, you need to have bilateral obstruction. I mean, to have that degree of creatinine increase, you have to have bilateral obstruction, right? Okay, very good. So what's your diagnosis at this point? Like looking at the UA and looking at the labs that they keep uptrending. What do you guys think is going on?
ATN.
Right. And the cause of the ATN, what do you think?
Hypervolemia.
Not hypovolemia, because remember he didn't drop his blood counts and everything was stable.
It's not hyperuricemia.
Hyperuricemia is a little bit high, but I put it there because a little bit of high uric acid doesn't explain AKI. When we talk about acute kidney injury related to high uric acid, we're talking about uric acid in the 14, 15, 16, 17 range, like something really, really high. And we only see that in the setting of tumor lysis. Okay. So what do you guys think? We talk about like what happened during surgery. His blood pressure went to 80, remember? Systolic blood pressure went to 80? Yeah, so he had a hypotensive episode. This is probably the more likely cause. And both the physical examination and the renal ultrasound confirmed that there are no signs of bladder obstruction or any ureteral obstruction. Okay, so how do you treat this patient? How do you guys treat ATN? I'll give you three options. Do you send him home? No. Okay. Do you give him some sort of medication, magic medication to treat this patient, or? Yes? No? Do you still give fluids? Do you want to give fluids? What do you guys want to do?
I'd give some.
Well, he's making little urine, right? And he's positive, net positive 3 liters. Do you still want to give him more fluids? No.
I see Lasix, but I don't know. Somehow they get nervous.
Yeah, so Lasix, we use Lasix in ATN with evidence of volume overload. Lasix does not change the outcome to make your ATN better. So
It just changes the physiology otherwise.
it just helps you urinate.
Gets you.
And sometimes you need crazy doses of Lasix. You need like 100 milligrams of Lasix times 1.
Yeah, I see Bumex.
Bumex, that's a loop diuretic as well.
Yeah.
Yeah. So remember, if you have